Hi, and welcome everybody to today's webinar on the topic of pairing the kidney, selection and management for dual transplants. My name is Heidi Aguiar, and I'm part of the Alliance team, and we welcome you to today's webinar. Before I introduce our moderator for today, I have a couple of housekeeping items. So for those of you who have not joined us before on a webinar, we do record these webinars, so the webinars, actually your line is going to remain muted. If you have questions for the speakers, on the bottom left-hand corner, there is a chat icon. Just click on that chat icon, type in your question, and then we will hold it towards till the end of the presentation and pose it to the speaker at the time. Coming up on October 10th is our next donation-focused webinar, and that webinars focus on the topic of the heart, the other thoracic organ, and registration is open for that. We are offering 1 SEPC credit for today, as well as 1.2 nursing contact hours, courtesy of Iowa Donor Network. Now, everybody who's listening to this webinar is entitled to continuing education credits. If you are needing nursing credits, just follow the evaluation process within 14 calendar days. And if you need SEPCs, just follow the evaluation process within 30 calendar days. So you have a little bit more time for SEPCs. Nursing, please note 14 days. Now, if you are in a group today, many of you listen as a group, whoever the registrant was for the webinar will be the one receiving the evaluation. So please make sure to ask them for the evaluation link, the evaluation email that we will send out later on today. And they can forward it to all of you so that everyone can submit the evaluations. So at this point, I would like to turn it over to Dr. Randy Sung. Dr. Randy Sung is a member of our Transplant webinar faculty, and he kindly organized today's webinar. And he's also a member of our Transplant Leadership Council. He's the Surgical Director of Kidney and Pancreas Transplantation and Professor of Surgery at the University of Michigan. So I'm going to turn it to Dr. Sung.
Thanks, Heidi, and welcome everyone. Today's webinar, as I'm sure you're aware, is about whether or not to pair the kidney with liver and heart transplantation. It's been over a decade since the liver transplant community convened their first consensus conference on patient selection for simultaneous liver kidney transplantation, in the recognition that these transplants potentially can take kidneys away from kidney alone recipients. And almost a decade later, and the topic is still of interest, and we still aren't completely clear on who to do simultaneous liver kidney on and who not to. And there's even more interest now that the OPTN has implemented selection criteria for SLK, which in some ways makes things easier, but in some ways makes things harder. In addition, heart transplantation has gone down a similar pathway, with there being increasing indications for simultaneous heart kidney transplant and an increasing number of patients that meet those criteria. Fortunately, we have two people who are very experienced in managing this dilemma to help us work through this. They are Pratima Sharma and Keith Aaronson. Pratima is a transplant hepatologist and associate professor of internal medicine at the University of Michigan. She is a health services researcher with research interests pertaining to liver transplantation outcomes, including liver allocation, simultaneous liver kidney allocation, renal dysfunction before and after post-liver transplant, renal failure, and disease recurrence such as hepatitis C and hepatocellular carcinoma. Keith Aaronson is the Bertram Pitt Collegiate Professor of Cardiovascular Medicine and a professor of internal medicine at the University of Michigan Medical Center. He is also the medical director of the heart transplant program and has varied clinical expertise and research interests across the whole spectrum of heart transplantation. And in our clinical program, he encounters this situation very frequently. So we're very fortunate to have both of them on to address this topic. And I'm going to turn first the speaker's platform over to Dr. Sharma.
Randy, thank you for your kind introduction, and I would like to thank Alliance for giving me the opportunity to present this webinar today. So in this talk, we are going to learn about renal dysfunction in patients with cirrhosis awaiting liver transplantation, the incidence and risk factors of renal non-recovery after liver transplantation alone, and advantages and disadvantages of pairing kidney with liver, and newly minted medical eligibility criteria for simultaneous liver and kidney transplant and safety net option. And Dr. Aaronson will cover the combined heart and kidney transplant outcomes and allocation. So the spectrum of renal dysfunction in liver transplant candidates extends from minimally elevated serum creatinine to full-blown renal failure requiring renal replacement therapy. These patients have high morbidity, increased burden of hospitalization, and resource utilization. In addition to this, these patients are also at a very high risk of dying while waiting for liver transplant. Additionally, high serum creatinine going into transplant in these patients is associated with also a very high risk of developing end-stage renal disease after liver transplant. These patients can present with acute kidney injury, acute on chronic kidney injury, or they have advanced kidney disease defined as stage 4 and stage 5 end-stage renal disease secondary to either diabetes, hypertension, or any other etiology. The incidence of acute kidney injury in hospitalized patients with cirrhosis is around 20%. The acute kidney injury could be prerenal secondary to hypovolemia or hepatorenal syndrome. Hepatorenal syndrome is one of the most ominous complications of decompensated cirrhosis and associated with a very high risk of death. Hepatorenal syndrome is of two types. Type 1 is acute onset and has a median survival of 2 weeks, whereas type 2 hepatorenal syndrome is somewhat insidious onset with a median survival of anywhere between 3 to 6 months. The renal causes for acute kidney injury could be acute tubular necrosis secondary to hypotension or drug-induced, or various glomerulonephritis and interstitial nephritis. There are many ways to measure renal functions. Serum creatinine is one of the time-tested biomarker of renal dysfunction. However, it is fraught by many limitations, especially in patients with cirrhosis. Patients with cirrhosis tend to have lower serum creatinine because of low muscle mass, poor nutritional status, and decreased synthesis of creatinine from liver. Creatinine clearance can also be measured by collecting 24-hour urine, but it is very cumbersome in patients with decompensated cirrhosis with ascites who are on diuretics. The other biological markers, which are like cystatin C or NGAL, they are not routinely used for measuring renal function. The other way of estimating renal function is using these equations like Cockcroft-Gault, Nonkeval, MDRD equations 4, 5, and 6, and the newest equation is CKD-EPI. And as you can see, all of these equations are creatinine-based. Some of them have body weight included in them. MDRD and CKD-EPI also has the gender as well as race included in them. There is a very poor correlation among the estimated eGFR and measured eGFR if the creatinine clearance is less than 40 ml per minute. MDRD4 and CKD-EPI overestimate eGFR in patients with cirrhosis, whereas MDRD6 is the most accurate one to estimate GFR in patients with cirrhosis. Liver allocation policy was changed in February of 2002, and it was based on a score called Model for End-Stage Liver Disease. This year marks the 15th anniversary of MELD-based allocation policy. MELD score is the basis of liver allocation, and it is also a measure of waitlist mortality. MELD score is the components of MELD score include creatinine, bilirubin, INR, and serum sodium. The few things about MELD-based allocation or MELD score is that creatinine is one of the only component of MELD score which is associated with high pre-transplant as well as post-transplant mortality. Since the implementation of MELD-based allocation system, the number of patients undergoing liver transplant with serum creatinine greater than 2 mg per deciliter has increased by 40%. Since then, there is also a 15% increase in the risk of post-transplant end-stage renal disease compared to the pre-MELD era. So we asked the question, can we predict this risk at the time of transplant so that these patients who are at a higher risk of developing end-stage renal disease, we can modify their risk factors and prevent ESRD in these patients. So we developed, based on the recipient risk factors associated with end-stage renal disease, we developed this renal risk calculator, which consists of 14 recipient risk factors, and you can calculate this risk on this website once you input all these numbers like age, race, etiology of liver disease, diabetes status, kidney function, bilirubin, albumin, serum sodium at the time of transplant, BMI of the patient, whether the patient is on dialysis or not, whether the patient is getting a transplant as an emergent transplant, whether the patient had a history of TIPS or previous liver transplant. When you calculate it, you get a number which is called which is a composite number called RRI, and this number basically tells you what is the risk of your patient compared to the reference patient to develop end-stage renal disease. And it puts your patient into a decile from 1 through 10. If the patient is in the 10th decile, their 1-year risk of developing end-stage renal disease is around 8%, and the 5-year risk is around 18%. And you can get this number here through this calculator. Not all patients who have renal dysfunction at the time of transplant need a kidney transplant along with the liver transplant. So who are those patients who probably will benefit from a kidney transplant? So in order to answer that question, we looked at the SRTR data from 2002 to 2010 of all the patients who underwent liver transplant alone and were on some kind of renal replacement therapy for less than 90 days. In our study, we found that the incidence of renal non-recovery in this highly selective group of patients was only 8%. The renal non-recovery was defined as transition to chronic dialysis within 6 months of transplant. And the factors that were associated with renal non-recovery were the length of pre-transplant renal replacement therapy. So every day increase in length of pre-transplant renal replacement therapy was associated with 4% increased risk of renal non-recovery. Similarly, age, previous transplant, and type 2 diabetes was also associated with high incidence of renal non-recovery. Since the adoption of MELD score, which was here in 2002, the number of simultaneous liver and kidney transplant has increased tremendously. So in 2015, there were 626 simultaneous liver and kidney transplant performed. So to put this number in perspective, in that year there were around 6,000 liver transplants. So the proportion of patients undergoing transplant from before MELD era has increased almost from 2% to 10%. So what are the advantages of simultaneous liver and kidney transplant? As I showed you in the previous slide, that some of the patients with renal dysfunction at the time of transplant have high likelihood of developing end-stage renal disease, and predicting the renal recovery is difficult. So giving them a kidney along with liver will prevent postoperative renal dysfunction, need for renal replacement therapy, and may prevent end-stage renal disease in these patients. However, the con is that if they have reversible, if their renal dysfunction reverses, then these patients end up with three functioning kidneys. Then also there is an added surgical risk associated with slightly increased mortality within first 3 months of transplant. And most importantly, we are draining the kidney from the kidney pool, kidneys away from kidney alone recipients. And these patients, as you will see in the subsequent slides, the high quality organs are going to dual organ transplant patients. So the decision of giving a single organ to a patient with decompensated cirrhosis without AKI is simple. Similarly, if somebody has end-stage renal disease or on dialysis and has decompensated liver disease, they should get simultaneous liver and kidney disease. However, this decision-making becomes a little bit difficult in those who have decompensated cirrhosis with sustained acute kidney injury, but they are not on renal replacement therapy, or decompensated cirrhosis with CKD and eGFR hovering around 29 to 30. And looking at the practice pattern of simultaneous liver and kidney transplant rates across the region, we found that there is a high variability in the rates of simultaneous liver and kidney transplant across the region. So, such as Region 1 has close to 11% of simultaneous liver and kidney transplant. Similarly, Region 7 has the highest rate of simultaneous liver and kidney transplant. However, if you look at Region 6, they only perform maybe 3.5% of simultaneous liver and kidney transplant. So as Randy alluded to, there was the first consensus conference, which was in 2008, and some criteria were laid down for optimal selection of candidates for simultaneous liver and kidney transplant. But this is a busy slide, but I just want you to tell that in 2006, SLKT was not recommended in patients with acute kidney injury not requiring dialysis. And in 2009, based on the consensus conference in 2008, OPTN laid down certain criteria, but these were not based upon, but these were only the suggestions. So patients with CKD requiring dialysis, CKD with eGFR less than 30 ml per minute, and proteinuria greater than 3 grams per day. Then those with sustained kidney injury with dialysis greater than 6 weeks, sustained AKI without dialysis, sustained AKI with combination of either without dialysis or complete, so in both the categories for 6 weeks, and the metabolic diseases like urea cycle defect, etc. So one of the centers looked at its 155 simultaneous liver and kidney transplant between 2002 to 2009, and this was one of the high-performing center for SLKT. What they did a renal scan to look at the estimated GFR from each contributed by each kidney from in their SLKT recipients. So as you could see, half of the patients got renal scan, whereas half of patients did not get renal scan. Out of the half who did not get renal scan, half of them died. So, and then 36 did not have the follow-up. So out of these 78 patients who underwent simultaneous liver and kidney transplant between 2002 to 2009 and got the renal scan, only 31 of them met the OPTN criteria for SLKT. And when they looked at the eGFR of native kidneys, they found that those patients who did not meet the OPTN criteria had higher eGFR, statistically significant higher eGFR compared to those who met the OPTN criteria. So suggesting that OPTN criteria is probably a good allocation or good suggestion for SLKT. In 2012, we had the second consensus conference, and based on that, again, the difficult category, which is AKI, sustained AKI, deemed irreversible for more than 4 weeks, there was a suggestion made that these patients should be considered for simultaneous liver and kidney transplant. So there are definitely selection biases involved in the analysis of SLK outcomes, secondary to differences in patient population. The cause of renal dysfunction is not known, and dialysis duration is only available for those who received SLKT. Duration of non-dialysis renal dysfunction is not known, and indications for dialysis vary in these patients. Despite these drawbacks, there are 2 studies that I'm going to show in which the outcomes of SLKT after transplant were compared to liver transplant alone patients with renal dysfunction. So this is the data from 1987 to 2006. Here, this graph basically shows the x-axis represents the months from transplant, and the y-axis represents the percent survival. As you can see, the patients this is the comparison between SLKT patients versus liver transplant patients who were receiving dialysis for greater than 3 months before transplant. And among those patients, the SLKT patients had better survival compared to liver transplant alone patients. Whereas those patients who received SLK or liver transplant alone with less than 3 months of pre-transplant dialysis, their survival were similar. So again, in this study here, this slide shows the matched control analysis of liver graft survival and the risk of graft loss among SLKT and liver transplant alone recipients. And if you look at these patients with long-term dialysis, the patients who received SLK had better 1-year survival with a hazard ratio of 0.57. This is a more recent study where the survival of SLKT and liver transplant alone patients with renal dysfunction, defined as serum creatinine greater than 2 mg per dl, were compared. And this was the propensity score matched post-transplant survival. In this slide here, this panel basically shows the patients who received SLKT or liver transplant alone but were not on dialysis before transplant. So in this category, the SLKT patients had better survival compared to those who got liver transplant alone. On the other hand, the survival was similar for SLKT and liver transplant alone patients with renal dysfunction if they were on dialysis before transplant. And we were talking about the organ quality, kidney organ quality. So before we discuss this slide, I wanted to introduce the term called kidney donor risk index, which combines a variety of donor factors to summarize the risk of graft failure after kidney transplant into a single number. The KDRI, which is Kidney Donor Risk Index, expresses the relative risk of kidney graft failure for a given donor compared to the median kidney donor from last year. Value exceeding 1 have higher expected risk than median donor and vice versa. The KDPI is a remapping of KDRI into cumulative percentage scale such that a donor with a KDPI of 80% has higher expected risk of graft failure than 80% of all kidney donors recovered last year. So here, in the case of patients who received liver and kidney transplant, their KDPI was 36, which meant that they have, so KDPI of 36, they have 36% has higher expected risk of graft failure than 36% of all kidney donors. And whereas the KDPI of kidney alone donor was 46, and this was the KDPI of heart and kidney transplant, lung and kidney transplant, and pancreas and kidney transplant. So all these patients got a better organ compared to kidney alone recipients. So what was the problem with SLK allocation? There was guidance, but no strict rules that governed SLKT. And as a result, the OPTN and also the Liver and Intestine Committee, they put forth this new SLK policy. So the SLK allocation was not based on any standard medical criteria for kidney function. Previous policy did not provide any clear rules for SLK allocation, and there were inconsistent allocation practices. So what is the new current SLK proposal? So there should be a medical eligibility criteria for local and regional SLK allocation, and there is also a safety net option, which means prioritization of kidney alone waiting list for liver transplant recipient with postoperative dialysis dependency or significant renal dysfunction. So what does that mean? That means that these patients can be listed, patients with renal dysfunction can be listed and receive liver transplant alone. However, if they develop post-operative dialysis dependency and transition to ESRD, then they can be prioritized for kidney transplant after liver transplant. So here is the SLK medical eligibility criteria. Chronic kidney disease with measured or calculated GFR less than or equal to 60 ml per minute for greater than 90 days. And they should document at least one of the following, which is dialysis for ESRD, most recent eGFR creatinine clearance at or below 35 ml per minute at the time of registration on the kidney transplant waiting list. The second category is the sustained acute kidney injury, and they should document at least one of these: dialysis for 6 consecutive weeks, or eGFR or creatinine clearance less than or equal to 25 ml per minute for at least 6 consecutive weeks, or combination of this and this. Then the third one is pretty clear, which is the evidence of metabolic disease. For example, diagnosis of hyperoxaluria, atypical HUS, familial non-neuropathic systemic amyloid, and methylmalonic aciduria. So because there has been a concern from the kidney community about access for highly sensitized and pediatric kidney candidates, and also for better utilization of kidneys through longevity matching, the priority would be limited within each allocation sequence. So sequence A with KDPI less than or equal to 20, here the lower number is better, the higher number is as compared to the higher number. In sequence A, which represents KDPI equal to or less than 20%, there would be no prioritization assigned to the safety net option. In sequence B, KDPI, which is the KDPI between 21 to 35%, these candidates would be prioritized after local pediatric candidates, since kidneys with KDPI less than 35% are typically prioritized for this population. In the sequence C, which is KDPI between 36 to 85%, these candidates would be prioritized after prior living donors. And KDPI, or sequence D with KDPI between 86 to 100%. These candidates will be prioritized after zero mismatch offers. It is important to note that the majority of all kidneys will be allocated within sequence B and C. This new prioritization would be limited to the local DSA. So in conclusion, SLKT rates have increased in the MELD era. Evidence supporting defined criteria for SLKT other than ESRD is weak, and new SLKT medical eligibility criteria may streamline the allocation of kidneys for liver transplant recipients. Thank you.
Thanks, Pratima. I'd be very interested to see what happens to liver kidney transplantation with the implementation of these new rules, and especially the safety net, and maybe we'll be able to come back to that. We're going to transition now to Dr. Aaronson, and I can speak from personal experience that we try to sometimes apply what we know about liver kidney transplant to heart transplant recipients, and there are some things that are similar, but there are a lot of things that are very different, which is something that I've learned over time, and I think Keith will be able to help us learn a little more quickly than I did. So I'll turn it over to Keith.
Well, thanks very much, Randy, and thank you all for joining us today. So I'm going to talk a little about the epidemiology of heart kidney transplantation and how that's changed over the years. Talk about the rationale for adding a kidney to a heart. What are the outcomes? Who seems to benefit? Does LVAD, which is increasingly the bridge to a transplant for most large percentage of our patients, does LVAD fix kidneys so that dual organ transplant is not necessary? And then just touch on some of the management considerations. So this graphic shows you the growth in heart kidney transplant listing and actual heart kidney transplants from 2000 to 2012. You see that the number of listings has gone up proportionately more than the number of transplants. You also see that while this is certainly worth 20 minutes of this webinar and maybe another few of questioning, and is certainly very worthwhile to those who get it, we're not talking about something that's a raging public health menace one way or the other, right? So we're at somewhere in the order of 50 heart kidney transplants a year. This is showing you, though, that nevertheless there has been a growth in the proportion of transplants that are heart kidneys. Thinking back to the last slide, we're not seeing that kind of trajectory in the number of heart transplants overall in the United States at all. It's pretty flat. So going from 53 transplants, heart kidneys, to 140 in that 10-year span, or I guess 11-year span, is about doubled the percentage of heart kidney transplants. And you see that the other dual organ transplants involving the heart are much, much less common. So what's the impact of renal insufficiency on survival after heart transplantation? So it's pretty clear that post-heart transplant outcomes are substantially worse in patients with CKD pre-transplant. And this is from a study that divided estimated GFR into 5 quintiles. The lowest quintile had estimated GFR of 37 mils per minute, and that's actually per 1.73 meters squared. Everything I'll show, whether I say that or not, I did do that. And what you see is that for the other 4 quintiles, it's not actually monotonic, and there's probably some noise in the data with respect to patient characteristics. But the one that really does stick out as being substantially worse is the lowest quintile, and that was highly statistically significant worse survival. Now, if we look at post-heart transplant outcomes with renal insufficiency post-transplant, that also is clearly worse. So in the seminal paper written by our former colleague here at Michigan, Akinlulu Ojo, his New England Journal paper in 2003 showed that about 11% of heart transplant recipients had developed stage 4 CKD, or eGFR of less than 30, by 5 years post-transplant. And pooling all of the non-renal solid organ transplants, the relative risk of death for those who were stage 4 or 5 CKD versus all others was 4.55-fold increased. So a clear marked increase. Of those heart transplant patients who had developed stage 4 CKD by 5 years, almost 30% of them went on to develop end-stage renal disease. And clearly, and as you'll see in the slides to come, actually I take it back, we don't show this in the slides to come, but non-simultaneous renal transplant does improve outcomes in these patients. The issue, of course, is that you got to be able to get one. And as you know, the waiting list for non-directed donor kidney transplant is quite long, and the mortality over the course of 5 years in patients who develop severe CKD, and once you go on dialysis, your 5-year survival with a heart transplant is about 60%. And contrast that with the annual mortality for heart transplant patients alone. After the first year, the annual risk of dying is about 3 to 4% per year. So clearly markedly increased in these heart kidney recipients who develop end-stage renal disease. Now, in last year, the International Society for Heart and Lung Transplant put out a guideline statement on heart transplant candidate selection. It's a rather sobering statement, particularly for cardiologists who deal with heart failure and MI and other diseases that affect hundreds of thousands, if not millions of people. Heart transplantation, really is a boutique kind of thing where the numbers are small. So in fact, almost all of the recommendations here are based on level of evidence C, which is just expert opinion. The recommendation here is that renal function should be assessed using eGFR creatinine clearance under optimal medical therapy. They didn't get at all into the issues with the accuracy of different estimation methods, as was just alluded to earlier in the context of chronic liver disease. Patients with chronic heart failure also have reduction in skeletal muscle mass, so there are issues with extrapolating from serum creatinine. They go on to say that evidence of abnormal renal function should prompt further investigation, including renal ultrasonography, estimation of proteinuria, evaluation of renal arterial disease to exclude intrinsic renal disease. They don't actually make any specific recommendation about renal biopsies. And they go on to say that it's reasonable to consider the presence of irreversible renal dysfunction with an eGFR less than 30 as a relative contraindication for heart transplant alone. There's no statement about these patients then necessarily being eligible for heart kidney transplant, but that would be the implication. So how easy is it to predict renal recovery post-heart transplant? And the fact is it's extremely difficult to predict. We don't have time here to go into the factors that lead to lead to cardiorenal syndrome, but suffice to say that hemodynamics play a relatively modest role. At least cardiac output plays a modest role in the development of cardiorenal syndrome. The evidence suggests that central venous pressure plays a much more profound role, but there is increasing evidence for a very strong immunologic role. One might think that transplant and the ensuing immunosuppression might affect that, but of course that might be so if we were giving powerful nephrotoxic medications following transplant. Clearly patients are less likely to recover if they have intrinsic kidney dysfunction. If patients have long-standing renal dysfunction, they're less likely to recover. Ultrasound is frequently done looking to exclude small shrunken kidneys. Normal kidney size certainly doesn't give you any assurance of recovery, but small shrunken, scarred down kidneys with thin cortex certainly does dramatically reduce the likelihood. Looking for proteinuria, and then in selected patients, when guided by the clinical information or the results of testing, a renal biopsy to look for intrinsic renal disease. Now what about left ventricular assist devices? An increasing proportion of patients nowadays get to a transplant using a left ventricular assist device as a bridge to that transplant. And one might think that if you increase cardiac output and perhaps reduce right-sided pressures by unloading the left ventricle, making it easier for the right ventricle to work, that you would see an improvement in kidney function. So this is from a recent article that looked at MCS is mechanical circulatory support. So it looked at estimated GFR prior to the institution of mechanical circulatory support, and then what happens over time. And you see that for each of the groups shown here, clearly these are not mutually exclusive groups. You see an improvement in kidney function that's overall rather dramatic, occurring in the first week. Some slight further improvement over the next few weeks, and then a gradual decline to a point where you're moving back toward where you were with about a 5 to 10 mil per minute normalized increase in kidney function, or reduction in increase in creatinine clearance, eGFR. Perhaps a more informative way to look at it is this way. So what was done here is eGFR greater than or equal to 60 versus less than 60 is shown in blue and red respectively. And then you see patients who are also stratified by the presence of improved renal function or not. And improved renal function was defined as a 50% or more increase in estimated GFR within the 30 days post-transplant. So not surprisingly, when you look at these sets of curves, you see the solid lines, which are those that had improvements in renal function, do go up, and the other group doesn't. That's not so surprising. But what you also see is that there's relatively little change in the eGFR in those who don't have an immediate improvement. And on the converse, those who have a substantial early improvement go on to experience fairly rapid progressive loss. Probably the most important curve to focus on here is the solid red line at the bottom, where in fact we see a significant increase, a substantial loss, but on average there was an improvement. So these people maintained about half of the improvement in renal function that they initially experienced. Now the folks who didn't have an initial improvement really didn't change their eGFR at all. And of course, you don't know which group your patient's going to be in until you do the VAD. But certainly, this can be. There are some patients who do have some improvement on ventricular assist device therapy, and you would know that at the time that you would consider them for subsequent make a decision about heart or heart kidney transplant. If you look at this, if you look at groupings of kidney function, I think that's also informative. So, focusing on the bottom two groups, the hashed brown and red, and the red bars, you see that the percentage of patients with eGFR is less than 30, and those who are between 30 and 60 both do decline modestly over the course of the year. Recognize though that there is selection bias here, in that you see the numbers available at each time, and some of the patients presumably who either died or got transplanted early have been pulled out of here. So you're going to see people pulled out for both likely with worsening and improving kidney function. Now, does heart kidney transplant improve outcomes in heart transplant candidates with advanced CKD? So first, let's talk about what happens while they're waiting. So waiting list mortality in dialysis-dependent patients is really exceptionally high. You see the numbers there for heart transplant alone and for heart kidney transplant at 3 and 12 months. And note that those waiting list mortalities are similar to what we expect in patients who are UNOS 1A listed for heart transplant. So that's patients on 2 intravenous inotropes or 1 intravenous inotrope at high dose, or people on a left ventricular assist device with complications. It's certainly higher than the present 1As who just are getting 30 days of elective 1A time on a ventricular assist device. The waiting list mortality in non-dialysis dependent renal insufficiency patients, which here was defined as a creatinine clearance of less than 50, is also high and similar to the mortality for UNOS 1B heart transplant waiting list patients, and that's listed below. If you compare the survival for heart kidney transplant patients to those who are listed for a heart and received a heart with an eGFR of less than 37, that lowest quintile from the study I showed you earlier, survival is better for those who received a heart kidney. This was from a separate study using UNOS database. And here is unadjusted raw data showing you over 20,000 patients who received a heart transplant alone versus those who received a heart kidney transplant. It's not really important to figure out which curve is which because they are pretty much identical. So no difference in unadjusted survival. Here is is limited. This analysis is limited to those who are dialysis dependent. So you see the relatively, here's my pointer here, relatively small numbers. And here we're doing propensity matching. So we're matching for the likelihood of getting a heart kidney transplant. So we've got relatively similar folks in both groups. And when you do that, you see that heart kidney transplant actually had markedly better survival than heart transplant alone. And now the same analysis, again with propensity score matching, but now restricted to those patients who are not dialysis dependent but do have a creatinine clearance of less than 50. And again, you see better survival, although the magnitude of the difference is not as large in those who got a heart kidney transplant. And when further multivariable analysis was done, heart kidney transplant did result in better outcomes than heart transplant in those who were initially listed, who were listed for both organs. So some of the people listed for dual organ transplant just got the heart. The heart kidney transplant recipients did do better, although both procedures improved survival. Again, the magnitude of benefit is greater in those who are dialysis dependent than those who are not. It's important to realize, though, that there is selection bias in these observational studies, and that's absolutely inherent. There really is no way of using statistics to eliminate that. So patients who are hemodynamically unstable following a heart transplant may not receive the kidney transplant, right, because it's done sequentially. So the denominator in the analyses of heart kidney transplant includes only those who receive both organs. It doesn't include those who had a problem with the heart transplant. So analytic techniques that risk adjust using baseline characteristics can account for what has happened beyond the baseline, which is what happens post the heart transplant decision not to implant the kidney. So it's important to recognize that there is some inherent bias that you just can't adjust away. What about doing mechanical circulatory support? We know that going back in to the chest another time tends to result in worsening outcomes. We know that for heart transplantation, the number of prior sternotomies you had is a very strong risk factor for a worse outcome, as it is for outcomes in people who get mechanical circulatory support. That was not seen in this analysis, although one, if you look at the point estimates here in the table on the left side of the screen here, you do see that the point estimates are for better outcomes in those who did not previously receive mechanical circulatory support, and there may be a type 2 error here due to the small numbers. What about what happens to renal function post-heart kidney transplant versus heart transplant? Interestingly, there is more acute kidney injury, greater need for early post-op dialysis, even compared with heart transplant recipients in the lowest quintile of eGFR. So in one large study, the incidence was 9% overall in heart transplant recipients, 22% in in heart transplant alone recipients in the lowest quintile of eGFR, but 26% in heart kidney transplant recipients. Nevertheless, at 1 year, kidney function is the same and renal allograft survival is the same. Heart kidney transplantation results in less rejection than hearts and heart transplants or kidneys and kidney transplants. So heart kidney transplant recipients have longer time to first heart or kidney rejection, fewer rejections at 1 year, and fewer rejections overall than do heart transplant alone or kidney transplant alone recipients. And there's a bunch of theories which are alluded to there, but they're all theories. Interestingly, there's a lower incidence of cardiac allograft vasculopathy, the immune-mediated phenomenon that occurs in the arterioles of whatever solid organ is being transplanted. We certainly know more about it in the hearts, I think, than the other organs do because we spend more time looking at their vessels. In terms of management considerations, early post-op, obviously it's key to maintain adequate renal perfusion. I mentioned the greater need for early post-op dialysis. Preventing and treating right heart failure is critically important. About half of early heart transplant deaths are due to right heart failure, and it tends to have long-term consequences in those who survive. The other issue is that, as I alluded to earlier, cardiorenal syndrome seems to be driven in substantial part by elevated right-sided pressures. So if you have more right heart failure early on, that likely contributes to progressive early kidney dysfunction. There is a tendency to use more induction therapy. In kidney transplant in general, more centers are using induction therapy. It's relatively uncommon in heart alone centers with selected use in heart transplantation in patients who are having more early kidney dysfunction. Certainly in our center, abbreviated induction protocol of 2 or 3 doses of thymoglobulin was pretty common. Delayed calcineurin inhibitor use has been shown in kidney transplant not in fact to improve outcomes. Of course, that's a little different than when you might see here when in heart transplantation, where quite frequently patients are getting significant numbers of vasoactive medications that may affect kidney function. So I think delayed calcineurin inhibitor use is probably a little more common. In terms of chronic management, the intensity of immunotherapy is generally guided by the needs of the organ at higher rejection risk. If you look at heart transplant protocols, we're generally using higher levels of calcineurin inhibitors, so patients tend to get them, and that may in fact be responsible for some of the reduction in kidney transplant rejection that's seen in these patients. On the other hand, most heart programs will have a proportion of their patients at least who withdraw from steroids, and that's less common in treatment of kidney transplant recipients, and I think that's reflected in the dual organ management. Probably important to note that calcineurin inhibitor-free mTOR inhibitor-based immunotherapy is relatively contraindicated as initial early strategy in heart recipients on the basis of the SAVE the Nephron trial. So just to conclude, I think heart kidney transplant is the treatment of choice for heart transplant candidates who are dialysis dependent. It's also the treatment of choice for heart transplant candidates who are non-dialysis dependent, who have CKD stage 4 or worse, without, and in both cases, without a high likelihood of recovery of kidney function, noting that the marginal benefit is smaller than for dialysis dependent patients. And when you consider HKT versus heart transplant alone, recognize that early dialysis and infection are more frequent, rejection and transplant vasculopathy are less frequent, and malignancy occurs at about the same rate. And that's what I have for you.
Thank you so much, Dr. Aaronson. That was a very, very thorough presentations by both speakers. Thank you both so much for your time. We have a few minutes left for Q&A time. I'll turn it back to Randy here in just a second, but for those of you who are wanting to submit some questions, on the bottom left-hand corner, just type in your question. And while we're doing the question and answer time, I'll have this poll up for those of you listening in a group. If you can please submit how many people are in your group on the poll, and I'll turn it back to Dr. Sung.
Okay, great. Thank you both so much. Because while we're waiting for questions, because this is a pretty complicated topic and a lot of people may not be very intimately familiar, I wonder if I could put each of you on the spot and have each of you give sort of a 30-second to 1-minute summary of what your own indications are for adding the kidney transplant. And in addition, for Pratima, how much does the possible presence of undocumented CKD play into it? And for Keith, what you presented kind of suggested that whether somebody is on a VAT or not may not be as important as those of us who were not heart specialists used to think when these patients came up. So I'll let each of you respond.
So Randy, if I understood your question well, so you want me to comment on the presence of undocumented chronic kidney disease among liver transplant recipients and what role does it play out in SLKT allocation?
Or really the decision, not so much the allocation, but basically your decision. How do you decide who needs a kidney? That's really kind of the bigger question.
So if we have a patient who had decompensated cirrhosis with end-stage renal disease and this patient is already on dialysis with complications of portal hypertension, we usually list them for simultaneous liver and kidney transplant. So that was an easy decision. I think the problem comes when somebody has acute kidney injury and on dialysis. Now it's week 6 and there is no signs of recovery, and so what to do with those patients. So previously, if these patients had history of diabetes along with this acute on chronic kidney injury and things like that, we used as our center used to get the nephrologist involved, and we see if it is more than 6 to 8 weeks of dialysis, then we used to list them for simultaneous liver and kidney transplant. However, with this the new criteria, I think in these kind of patients who have sustained acute kidney injury but they're still on the fence of whether they're going to have a recovery or not without any risk factors towards chronic kidney disease like history of hypertension or diabetes, I think this safety net option is a great option where if they do not recover their kidney functions or transition to end-stage renal disease within 1 year, then these patients can be listed for kidney transplant and may be able to get the organ within this medical safety net, under the medical safety net. Make sense?
Mm-hmm. Yeah.
So, but those patients who have acute kidney injury but they are not needing dialysis, usually we do not list them or we do not pair kidney with those patients.
Okay, great. Dr. Aaronson?
Yeah, I mean, I think we spelled it out. I mean, certainly, if somebody is on dialysis and we were going to transplant them, it'd be heart kidney. That one's pretty easy. Nowadays, it's the mean creatinine or the median creatinine clearance or eGFR of people that we transplant is probably only 50. When I think about what it was like when I started 20 years ago, and most, 2/3 of the people we transplanted were status 2. Those were people, waiting at home, and they probably wouldn't get pulled off the golf course playing golf, but they might be riding, the cart watching somebody. Nowadays, folks spend so much time and really have to develop such significant hemodynamic compromise before they get transplanted that it's uncommon to transplant somebody who doesn't already have fairly compromised kidney function. In general, if somebody has long-standing kidney dysfunction and now their creatinine clearance is less than 35, we'll be asking our colleagues for for dual organ transplant. With respect to that, I think it's I think what you're seeing is the combined effect of influences on both directions. So certainly the next time you go into a chest, if a surgeon puts a VAD in and within 30 days is able to transplant that patient before before there's a bunch of scarring in the chest, the operation would be easier, but we know that outcomes are not nearly as good. That was the practice when VADs were first placed, but the person hasn't had a chance to recover yet. The reason why mortality post-transplant after VAD has changed and has greatly improved is because by the time you do the transplant, you've had a chance for end organ function generally to get better, and you've had a chance for the patient to become more conditioned, for them to begin exercising and to condition the rest of their body. They spend less time on a ventilator. Now those who are going for heart kidney transplant obviously are people who have not had recovery of their kidney function. But I think the rest of from other standpoints they're in better shape. So I think you're seeing the reason why VAD doesn't impact negatively on outcomes post heart kidney compared to those who go directly to heart kidney without a VAD is that on one hand it's a second operation and there's more bleeding in the chest and that raises pulmonary pressures, or it might be a third operation or fourth operation, right? They could have had bypass surgery or something else. On the other hand, the patients on VADs generally don't have heart failure at the time that they get the transplant.
Great. I have a participant question for Dr. Aaronson. Why is there less rejection in heart kidney patients, and which organ is the one that has less rejection?
So the answer to the first one is we don't know. In the old days, people used to talk about the kidneys just being a filter and sucking everything up. Then, of course, that should lead to more rejection in the kidneys, and it doesn't. Microchimerism is an attractive approach. Some of the other things that I mentioned there are really just hand-waving, immune, I can't remember what it was, immune fatigue or something. That wasn't the word that was used. I mean, it's obviously a kind of a silly notion to me. I mean, there's so much antigen present on one organ. It's not like you need the second one to present more antigen. And then which organ has less rejection? To some extent, that's not knowable. By the numbers, you would say the kidney has a lot less rejection. But of course, my nephrology colleagues don't biopsy nearly as often as we do. They might have a lot more. Obviously, you decide to do a kidney biopsy. There's usually some programs do surveillance biopsies, others don't. And even if they do it, they're doing it, maybe a couple times in the year or something. And we biopsy on average 17 times in the first year. So it's really a somewhat unfair comparison.
But the heart clearly has less rejection, and the heart clearly has less rejection in the heart kidney compared to the heart alone, right? That's what the
heart has less rejection in the heart kidney than the heart alone, and the kidney has less rejection in the heart kidney than the kidney alone. That part is clear. Yep.
Okay. Yep. Fascinating. All right, great. Well, because it is 4:03, we're going to wrap it up. I want to again thank both the speakers for their perspectives and a lot of great information, and hopefully this will help people in their clinical practice. And I'm going to turn it back to Haiti to wrap up.
Yes, I'd like to echo Dr. Sung's comments. Thank you to both of our speakers, Dr. Sharma and Dr. Aaronson, for your time and sharing your expertise. Thank you as well to Dr. Sung for moderating and doing a great job in organizing this webinar for today. And thank you to all of the participants for joining us today. I wish everybody a wonderful rest of the week. And for the speakers, I'll move us back into the speaker room. Take care and have a great day.
Thank you.
Bye-bye.
Thank you.
Thanks.